Yes, dear friends, can you confirm is everything fine at your end? All right, so here let me just zoom in to show you this image. Okay, here what you can see, this, can you see that this gland over here, this gland is sublingual gland. This gland is sublingual gland. Okay, this gland is sublingual gland over here. And if you can see that, let me just add this duct. This duct is the submandibular duct over here, and this structure which has been marked is the lingual nerve. This is looping around the duct. Can you see that? Okay, and here if you see that this is the cut part of the mandible through which this nerve is coming out. This nerve over here is inferior alveolar nerve. And if you can follow this part, dear friends, over here, this nerve is coming, follow its continuity over here. This is also coming very close. What is this nerve? Can you make a guess over here? Can you make a guess over here? What is this structure? Yes, dear friends. What is this? This is hypoglossal nerve. This is hypoglossal nerve. Making sense? Okay. This is hypoglossal nerve over here. Okay. And here you can see the artery. This is the artery. This trunk is the artery. This artery is superior thyroid artery. Superior thyroid artery. And here we have the hyoid bone over here. Just a moment. This is the hyoid bone over here. This is the thyroid cartilage over here. Okay, so this membrane, can you see this membrane? This membrane is pierced by let me show you this way. This is the hyoid bone over here. This is the thyroid cartilage, है ना? In between, can you see this membrane? Can you see that? This membrane is pierced by this nerve. Can you see that? And this artery, this is superior laryngeal artery, branch of superior thyroid artery, and this is internal laryngeal nerve. Both the superior laryngeal artery and the internal laryngeal nerve, they are going to pierce thyrohyoid membrane. Do you appreciate this? Okay, and along with that, one structure, if you guys can identify, there is something which is making a loop over here. What is this? Can you identify this loop of the nerve? We have the superior and the inferior root. This is nothing but called as ansa cervicalis. Ansa cervicalis. Okay. So what is A here is the inferior alveolar nerve. What is B? B is the hypoglossal nerve. What is C is the lingual nerve. And what about the D structure? D structure is the here we have the facial artery and the lingual artery. So facial lingual trunk is going, which will further divide into facial and the lingual artery. So among these, answer will be, obvious answer will be C. Yes. Now, as I said, answer is obviously easy. That is lingual nerve. We have practiced this part. This is a schematic diagram. Lingual nerve looping around the duct. This is the hypoglossal nerve, but sometimes in the INICET especially, they have the tendency to give you the dissection images. So I have discussed this dissection image. Can you please give me quick feedback? Did you understand these important structures over here? I have only highlighted few important nerves and arteries over here. Did you understand this much part? Is that all over? Okay, dear friends, could you understand this? Yes. Now let us move on and let us look at this question. Question number 2. Where we have got two columns, because one of the way of asking question is like match the columns. So we have got column A and column B. Now if you can match pterygopalatal ganglion, this side we have the preganglionic fibers. From where the fibers will be coming? Pterygopalatal ganglion. From where the fibers will be coming? Pterygopalatine, as we all know, it is concerned with the lacrimation. So the nerve of lacrimation, that is greater petrosal nerve, that will be relaying over here. Otic ganglion which is held by the mandibular nerve. It is concerned with the salivation from the parotid gland, correct? So it is the lesser petrosal nerve which will be relaying here. All right. Submandibular ganglion, okay, which is related to submandibular gland. And we all know our coda tympani nerve will be approaching the lingual nerve. But who is bringing the preganglionic fiber? Coda tympani nerve. So E will be there. And ciliary ganglion, for the ciliary ganglion, it is the nerve to inferior oblique. F, that will be the answer. Accordingly, we can think that. So far, so good. Right? Clear, no? This ganglion, foramen of skull, these are the important areas. Please go through them, okay? So we have been studying this, and I'm pretty sure you will be going to mark the correct answer, right? And as I told you earlier also in the class, that we have, as a team, we have like worked together, and I totally believe that you are gonna rock this time, okay? And also I will request you guys to believe in yourself and believe in God. All right. So B, A, E, F. Accordingly, what will be your answer? Answer will be this choice, right? This question, yes. Structures injured while resecting the free edge of the lesser omentum. See, this lesser omentum epiploic foramen again is a kind of favorite area of the examiner. So that's why we are going to put this together. And yes, what will be your answer here? What will not be injured here? So we all know that free edge of the lesser omentum is having the portal triad structure, where we have the hepatic artery, we have the portal vein and the bile duct, but we do not have the hepatic vein. That will be not injured because it is not contained. We will discuss the anatomy, but just before that, sometime there is like bleeding is there because we have the hepatic artery, we have the portal vein, major vessels are there. So sometime to hold the bleeding, we press this structure, the edge of the lesser omentum. What is the name of that maneuver? What is the name of that maneuver over there? Can you please write in the chat box the name of the maneuver? And in the meantime, let me explain this. See, behind the stomach, there is a sac called as lesser sac. Let me tell you, when you take the patient for the laparotomy, you cut the skin, muscles and the peritoneum. When you enter the peritoneal cavity, that whole peritoneal cavity is called as greater sac, except for some small sac behind the stomach, that will be called as lesser sac, right? Now imagine some of our friend has gone behind the stomach. That means he is in the lesser sac. If he wants to get free, he will be moving right, and he will be reaching over here, that is behind the lesser omentum. But further, he can see the ray of hope, that is nothing but the epiploic foramen. Do you appreciate this? And what is the boundary? We can see the boundary. This is the stomach, this is the pylorus. So that will be the first part of the duodenum. Can you see? With respect to epiploic foramen, there's the first part of the duodenum, that is floor. Above we have the caudate lobe of liver. In front we have the lesser omentum. Which part? This is the lesser omentum. That will be the right free edge. In this right free edge, we have the portal triad structure present, but we can't see the posterior boundary over here. So to see the posterior boundary, we will take a section. When you take a section, you will get this picture over here. You will get this picture right here. What you can see here, you can see, dear friends, that this is liver, this is stomach, this is spleen, these are kidneys, this is vertebra, aorta, IVC, and the right suprarenal, correct? And let me zoom in to show you. This is the stomach, this is behind the stomach. Can you see this sac? Behind the stomach we have small sac called as lesser sac, and this is the position of the epiploic foramen, correct? Now behind the epiploic foramen we have IVC, right suprarenal gland, and the vertebra. And also in this diagram I would like to show you, this is the lesser omentum, this is the right free edge. In the cut section it is showing portal vein, P4 portal, P4 posterior. Position of portal vein is posterior. So we have two structures anterior, hepatic artery and bile duct. So hepatic artery will be on the left side, bile duct will be on the right side. D for duct, D for dexter, means right. So anterior we have two structure, and out of these two, duct will be right side. Could you appreciate? Is everything fine up to this much part, dear friends? Yes? Can we move forward? यहां तक का समझ आ गया आपको सबको? क्लियर है? Boundaries of the epiploic foramen, lesser omentum, right free edge, what is lesser sac, what is greater sac, all these in nutshell, could you understand? And the arrangement of the portal triad, वो भी समझ आ गया. Pringles maneuver, everything fine up to this much part? So far so good? Let us discuss this. Again, this is again favorite area, important area. Almost all the exams, whether the central exam or the NEET exam, they ask on this Trendelenburg sign. Okay, so the patient, okay, got IM injection, okay, and after that he is now having difficulty. When he is raising the right foot off of the ground, his right hip is dropping. My question, if the right foot is dropping, in which buttock he has taken the injection? Because it was the duty of that particular side of muscle. If the right hip is dropping, it was the duty of left sided muscles. That means the patient has received injection in which buttock? Left buttock. In which quadrant? Answer will be superomedial quadrant. Superomedial quadrant. Because it is the superolateral quadrant which is safer, where we should give. But by mistake, this patient received in the superomedial aspect. Let me just show you this diagram. Here we should have given. Here by mistake he got. That's why superior gluteal nerve is involved. And let me talk a little bit in brief about gluteus muscles, because all of them are named gluteal. They are coming from the gluteal region, fine, but their action is different. Why? Because their direction, the final pull will be different. Look at the gluteus maximus. It is coming from the gluteal aspect, and where it is attached? In the posterior aspect of the femur, okay, gluteal tuberosity, and the direction becomes like this. So the pull will be from behind. The pull will be from behind. What is the action of the gluteus maximus? It is the chief extensor. When the powerful extensor is required, then it is doing the chief extension work, okay. But as per the fiber's direction, it has the tendency to do the abduction, and also it can do the lateral rotation. So I am writing in the this bracket, because its major action is chief extension, but abduction and lateral rotation it can do. But look at the gluteus medius. It is coming from the gluteal region, and then it is coming onto the lateral aspect of the femur. So see this. And what about the gluteus minimus? From the gluteal region, to the anterior aspect of the femur. So let me show in succession. See this. Gluteus maximus coming from behind, attached behind, posterior of the femur, lateral of the femur, and anterior of the femur. So behind, lateral, anterior. Are you able to follow? Maximus, medius, minimus. That is how the fibers are arranged. Could you appreciate, beta? Can you please confirm? Did you understand, everyone? ये पॉइंट समझ आया है आपको कि यहाँ पे फाइबर्स का डायरेक्शन ही चेंज हो गया ना, भले ही सारे ग्लूटेल से आ रहे हैं, दैट्स ओके. So here what we can say that these muscles, right, they are doing powerful abduction, and they are doing medial rotation also. So this is like, in this concept we have learned two things, because sometimes they give marked area on the bone, okay. If they mark on the posterior aspect of the femur, how will you identify it is posterior femur? Because in the posterior of the femur we have a thick line called as linea aspera, so thereby we will be able to identify this is posterior of the femur, correct? So posterior femur, gluteal tuberosity, if it is marked, then which muscle is attached? Obviously we know posteriorly who is attached? Gluteus maximus. If they give greater trochanter and the lateral side marking is there, then we will mark gluteus medius. If anterior marking is there, then we will mark gluteus minimus. So this is something very, very important. Yes. So yes, that is all. Could you understand? So far so good. Is this orientation clear to you? Fine, no? And here what I have told, that the patient received by mistake in the superior medial quadrant. That's why superior gluteal nerve is gone. Now superior gluteal nerve is going to supply these muscles, gluteus medius and minimus. Let me write in the same notes here. So these two muscles will be supplied by superior gluteal nerve. This will be supplied by inferior gluteal nerve. Okay. So when you are raising the right foot, suppose this is the right foot you have raised, you have taken it off of the ground, then there is no support. That pelvis should tilt on this side, correct? When the pelvis is tilting over here, the left side muscle will start contracting. They will prevent the tilt. So in reality, even if you put the foot off of the ground, the pelvis will not tilt. Why? Because left-sided muscles are contracting. Suppose the left-sided muscle cannot contract, then right tilt will be seen because there is no one to prevent the tilt. This is called as Trendelenburg sign. Could you understand now? Everyone, yes? ठीक है बेटा. Shravan Subramaniam, now I have explained all in, like, I have revised everything. It is now making sense to you? Everyone fine? Okay, so we will move on to the next question then. Which of the following finger is having two dorsal interossei? What is your answer? And let me describe this muscles action. We have palmar interossei, pad, dorsal interossei, dab. ठीक है बेटा? Palmar does the adduction, dorsal does the abduction. Look at this part. What is adduction? Coming towards the axis, coming towards the axis. So here we can say this finger can be adducted, yes. This finger can be adducted, yes, but middle finger is already in the axis. It cannot be adducted. If it cannot be adducted means it does not need the muscle for the adduction. That is, palmar interossei will be absent in the middle finger. So palmar interossei will be absent in middle finger is the answer, correct? But now we apply the knowledge for the abduction. Abduction means this finger can be abducted, yes. This finger can be abducted, yes. But middle finger, which is already in the axis, we can't really adduct it. But can you abduct? Yes. Because if this is the middle finger, you move it this way or move it this way, it is away from the axis. Can you see? Axis is fixed here. Middle finger we can move this way or this way, it will be away from the axis. So it cannot be adducted, but it can be abducted in both the sides. It can be abducted this way or in this way as well. That means, dear friends, we can say it will be requiring one dorsal interossei for this side and one dorsal interossei for this side. Total dorsal interossei are 4 in number. 2 are already used. So one will be taken by the index and one will be taken by the ring finger. So basically, which finger is now devoid here? Thumb is devoid of dorsal interossei. Little finger is devoid of dorsal interossei. But which finger is having two dorsal interossei? That is middle finger. Is this concept clear, beta? Are you understanding? So we are going like some high yield concept I have taken today, okay? And I know that you guys are really working hard and definitely you will be able to crack the exam. My question now, if the thumb and the little finger do not have this dorsal interossei muscle, how will be their abduction done? Who will do their abduction? Who will do their abduction? That will be done by their own. They have their own abductors. Abductor pollicis brevis, thinner muscle, and abductor digiti minimi, hypothinner muscle. So that's why they don't even need that. Okay, they don't even need basically that one. All right. Now, next question: false structure about false statement about the mark structure, right? And here I have put one labeled picture for you, okay, like this, and I would like to describe one thing, that whenever you see the hilum part, okay, where you can see these structures which are present at the root of the lung, you will see one nerve in front of it, that will be phrenic, and one nerve behind it, that will be vagus. Please remember that. Rest of the bigger structure you will be able to identify, but please remember two nerves. Phrenic is anterior to the root of lung, vagus will be behind the root of lung. Now based on this, right, based on this, what we can say, that we have this structure which is marked. Now can you identify what is this nerve? It is going behind, no? Is it phrenic or vagus? What is this nerve? This is definitely vagus nerve. It is definitely vagus nerve. And what is this nerve now? Can you tell me what is this nerve? This X nerve. What is this X nerve? This is phrenic because it is in the front. So now that you have identified this, okay, and let me ask the statement about, now thinking it to be vagus nerve, it is a content of the posterior mediastinum. Yes, vagus will follow the esophagus, so it will be seen in the posterior mediastinum. It will be passing through the esophageal opening. Yes, it will be passing through the esophageal opening. It will be passing through the central tendon. No. It will undergo rotation with the stomach. Yes. So answer will be C. because central tendon we have the IVC opening, along with the IVC right phrenic nerve will be passing through. So are you able to identify these structures? Yes. Next question, X-ray is given to us, and in the X-ray the fracture shown is the shaft of the humerus is fractured. If the shaft of the humerus is fractured, which of these nerves is likely to be injured? So we know that at the shaft of the humerus behind we have a groove, spiral groove or the radial groove. Who will be passing from here? That is radial nerve. That is radial nerve, correct? So just to show you this part, with respect to the humerus, three nerves are directly related to it. Around the surgical neck of the humerus we have this nerve, axillary nerve, okay, and around this part over here we have the radial nerve, okay, and behind the medial epicondyle we have the ulnar nerve. These are directly related. Also, I would like to show you one more thing over here. Please pay attention. Posterior interosseous nerve is very close to, posterior interosseous nerve comes very close to neck of the radius. If the fracture of neck of the radius is there, which nerve is at risk of injury? Posterior interosseous nerve, okay. And the posterior interosseous nerve is basically if it is injured, it will lead to the finger drop, only finger drop, without wrist drop, okay. Now dear friends, next question is this: a patient suffered from extradural hemorrhage due to involvement of the most common artery responsible for the condition. Now which artery is responsible most commonly? Middle meningeal artery. Middle meningeal artery anterior division, that is responsible for it, and it will be present. What will be the location of the injury on the skull? That will be pterion. That will be pterion. So this is the pterion where we have the anterior division of middle meningeal artery, okay, that is responsible for the extradural hemorrhage. All right. All right. Just to show you where is the asterion present. Asterion is the posterior end of the parieto-mastoid suture. Here you can see this is the line, this is the mark which is called as pterion. This is the part which is called as asterion. All right. And also just to show you what is nasion, it is the anterior part where this internasal and the frontonasal are meeting, okay. And where is the inion? It is the highest point of the external occipital protuberance. Just to show you where these points are present, right? But otherwise pterion is the most important part. Deep to it lies the anterior division of the middle meningeal artery, which is a branch of first part of maxillary artery. All the points are vital for you. Now the next question is this, dear friends, where we have the muscles like triceps brachii doing the extension of the elbow straight away. Supraspinatus, initiation of the abduction, yes, that is 0 to 15 degree. Pectoralis major will be doing the action made, medial rotation, adduction and flexion, that is also true. And lumbricus doing the MCP flexion, IP extension, so all are correct. But here let me tell you that we have a group of muscle lady between two majors, okay. Here we have latissimus dorsi between the teres major and the pectoralis major. This whole muscle action can be remembered by one mnemonic, that is made. That is made. What is M is medial rotation, what is AD is adduction, what is E is extension. But extension ke liye we will put the star over here and we will write that pectoralis major, because the muscle is in front, it will be doing the flexion. So pectoralis major will be doing the flexion. Now how to use this mnemonic? If the question is asked on the latissimus dorsi and teres major, latissimus dorsi and teres major, they will be doing all three components of made. They will be doing medial rotation, adduction and extension. But if the question is asked on the pectoralis major, for the pectoralis major, it will be doing medial rotation, it will be doing adduction, but it will not be doing the extension, rather it will be doing the flexion. Could you understand this? And pectoralis major, it belongs to what? It belongs to spiral group of muscle. Okay, I hope this is all fine. Now this question where the nerves and the action is given, so that is again important part. Facial nerve will be giving one branch which is coda tympani, responsible for the taste from anterior two-third of tongue. So one will go with the B. Spinal accessory supplying the trapezius muscle required for shrugging of the shoulder, A. Alright, glossopharyngeal nerve from the posterior one-third of tongue, that will be C. Mandibular nerve for the chewing, B, A, C, D. That's why answer will be C. Correct? So far so good, dear friends. Could you understand? Fine, everything up to this much part? Next concept is this stellate cell, because histology also like kind of histology is asked in the INICET exam. Okay, and particularly space of Dissay is, it has been asked twice. Okay, so stellate cell will be seen where? In the space of Dissay? Yes, it will be seen in the space of Dissay. What will not be seen in the space of Dissay will be the Kupffer cells, right? Let me discuss the histology with you. So this is the enlarged picture where you can consider this is the sinusoid. This is the sinusoid, and here you have the hepatic plate. Between the sinusoid and the hepatic plate, can you see this is the space? This is the space of Dissay. Hepatic stellate cell or the AIIMS cells will be present here in the space of Dissay. But the Kupffer cells are the phagocytic cells. They will travel within the sinusoids. That means we can say Kupffer cells will be, you can say they will patrol along the space of Dissay, not in the space of Dissay. That is something very, very important for us to understand. Now, what is the role of the AIIMS cells or the hepatic stellate cell? What is their role? They will be involved in the fat storage and the fat soluble vitamin storage. And what is their pathological role? They are involved in the formation of the fibrosis. They will produce the fibers, right? So next question, epithelium with the brush border will be seen where? So I told you the mnemonic, okay, brush border, P for PCT, P for present. It will be present in PCT. Okay. Oh, one doubt that you are asking. All right. So basically, if I ask you what is the source of nutrition for the liver, you will say portal vein, correct? Where from the portal vein is coming? It is coming from the GIT, right? That means it is full of nutrients. But is it a arterial blood or the like venous blood? It is majorly a venous blood, so it will be not very high in the oxygen. So we need another source also, hepatic artery. So hepatic artery will be coming, portal vein will be coming. They both of them, they will put the blood into the sinusoid. Both of them they will put the blood into the sinusoid, and these are the hepatic cells. They are sitting in a line between the sinusoids and the hepatic cells. There is a gap. It is just like we are sitting in a mess. We are sitting on our bench, and the table is there. In between the food and us, we have a gap. That is space of Dissay. Could you understand? Just very, you can say, as you have asked this doubt. Okay, I hope now you got the understanding where exactly the space of Dissay is present. Is that all okay? And these are the important questions which are asked. So also look at the questions along with the orientation, right? Now mnemonic was P for present, P for PCT. Brush border is present in PCT. Remember this. Okay. Here you can see the diagram. We have the brush border which is present in the PCT. Other than that, we do not have the brush border present. We have the simple cuboidal epithelium. Even in these tubules, we have the simple this epithelium is there, but we do not have the brush border. Could you appreciate this? Now the next question, read the question and tell me what is your answer. Assertion is left superior vena cava drains into right atrium by the way of left horn of the sinus venosus. Okay, that is coronary sinus, and the reason is it is the persistence of left anterior cardinal vein. Yes, is this correct? Both A and R are true, right? Let me explain how. So here, like normal circumstances, we have this is sinus venosus, where we have left horn and the right horn, and here we have anterior cardinal vein, posterior cardinal vein, and common cardinal vein. Like that, you can see anterior cardinal vein, posterior cardinal vein, and common cardinal vein. In normal circumstances, what happens that we have the anastomosis coming from left to right, like this. In this case, there will be formation of superior vena cava on the right side. This is the normal formation. We have the left brachiocephalic, we have the right brachiocephalic, and the superior vena cava is formed here. But instead, if you compare this, instead, if the anastomosis, instead of going this way, it comes in this way, just opposite. Let me draw and explain. Instead, if it occurs this way, that we have sinus venosus, okay, left horn and the right horn, and like this. Instead, the anastomosis is going this way now, like this, and this is the brachiocephalic vein. Where is the superior vena cava now? The superior vena cava is present on the left side. Superior vena cava is now present on the left side, but in which horn it is opening? It is opening in the left horn, and the left horn is eventually becoming what? Coronary sinus. So left superior vena cava will be opening into the coronary sinus. Could you appreciate now? So that is why both assertion and reason are true, and the R is the correct, reason is the correct explanation for the assertion. Now in the next question, tell me what do you think will be the answer? Yes, इसमें आंसर बताओ क्या होगा? A patient coming with the known history of lung cancer, now presenting with the hoarseness and the difficulty of the swallowing, and there is loss of gag. Can you tell me, for the gag reflex, what is the afferent nerve and what is the efferent nerve? For the gag reflex, what is the afferent nerve and what is the efferent nerve? Gag reflex afferent will be ninth nerve and efferent will be 10th nerve. So if in a patient there is a loss of gag, it can be either ninth gone, or it can be 10th gone, or it can be both gone. Are you understanding? Now in this patient, loss of gag is already given, and the hoarseness means laryngeal involvement, difficulty in the swallowing, pharyngeal involvement, and also the uvula is deviated. That means palate involvement. Palate, pharynx, larynx means VAC is involved, because this VAC, vago accessory complex, is going to supply muscles of palate, pharynx, and larynx. And along with that, when you do the shrug testing, this is the shrugging, right? Shrugging is done by the trapezius, which is supplied by spinal accessory nerve. So this is the history given, okay? And based on this clinical evaluation of the patient, now if you summarize everything, it becomes 9th, 10th, and 11th nerve. Now patient is a known case of lung carcinoma where metastasis must have involved. So we know 9th, 10th, and 11th nerve will be passing from the jugular foramen. That's why answer will be A. And very good to see that all of you have marked the correct answer. Very good, beta. Right? This foramen of skull is very important, है ना? हर बार क्वेश्चन, कई बार क्वेश्चन आ चुका है. इसको क्विकली एक बार रिवाइज कर लें. आप बताते जाओ. Okay, I will ask. Cribriform plate. Who will be passing cribriform plate? Cranial nerve 1. Optic canal, optic nerve. Okay. And here we have the fissure. Who will be passing from the fissure? 3rd, 4th, 6th, and V1 fibers. Foramen rotundum V2. Foramen ovale V3. Foramen spinosum, nervus spinosum. Then on the pectus part, we have internal acoustic meatus for the 7th nerve, 8th nerve, jugular foramen, 9th, 10th, 11th nerve, and the hypoglossal canal for the 12th nerve. Making sense, beta? Now this question, patient coming to you with the dry eye, and for the evaluation you do the Schirmer's test. You know the Schirmer's test is done for the lacrimation, okay, and which nerve will be basically involved for the lacrimation? So straightforward question. What is your answer? Yes, write your answer in the chat box. Yes, greater petrosal nerve. Very good to see that all of you are correct. Greater petrosal nerve, let me show you this way. It is the test that you have done, okay, for the lacrimation. And here we can say this is the seventh nerve. Let me revise this part. Seventh nerve is coming, making a bend over here. From the bend, greater petrosal nerve is coming. Here you can see the common carotid artery, external and internal carotid artery. Internal carotid artery and common carotid artery junction shows one swelling that is called as carotid body and sinus. And along the internal carotid artery, you can see the sympathetic fibers going, deep petrosal nerve, right? Greater petrosal, deep petrosal, okay? And here you can see the pterygoid plate. This is the pterygoid plate. With respect to this, we have the pterygoid canal. Can you see? So we have these two fibers coming together in the pterygoid canal, and in this segment they will be called as nerve of pterygoid canal or the Vidian nerve. Making sense? Now this is the pterygoid plate over here. This is the palate. One side pterygoid plate, one side palate. So what is this? Pterygopalatine fossa and the pterygopalatine ganglion. The fibers will relay, and that will be distributed to various regions, like it will be going to the nasal, palate, pharynx, and also to the orbit. In the orbit we have that is lacrimal gland there, right? So accordingly we can think this way, that greater petrosal nerve is majorly a nerve for the lacrimation. Making sense, beta? This part is clear. Now if you see from this view, you can see from above, this is the petrous bone. Above the petrous bone, yes, if you can identify now with me, what is this yellow nerve? This is greater petrosal nerve. What is this blue nerve? Deep to the petrous bone, it is deep petrosal nerve. And what is this green nerve over here? The green nerve over here is Vidian nerve, or the nerve of pterygoid canal, Vidian nerve. Okay, just wait, please wait. Okay, so this green color is what? This green color is the Vidian nerve. If I ask you, beta, one more nerve here, because with respect to petrous bone, this is the petrous bone, we have the greater petrosal. We also have one more nerve present over here. This nerve will exit from the foramen ovale. Can you tell me this red color nerve? Can you identify this red color nerve? This red color nerve, can you identify? This will be lesser petrosal nerve. It will be lesser petrosal nerve. Making sense, beta? Now, what is true for levator scapulae? It is supplied by dorsal scapular nerve. Very much true. It is supplied by C3, C4 fibers. Yes, proprioceptive fibers. These are the proprioceptive fibers. Action is elevation of the scapula. Yes. It will be also doing the medial rotation. Yes. So look at the levator scapulae and the rhomboideus. They are present in one line. So all of them, they are involved in the elevation and they are involved in the medial rotation in such a way that glenoid cavity is downward. So in this statement, all of them are true statements. Could you appreciate this? Okay. But for the rhomboideus, if they ask the major action, that will be retraction along with the trapezius. Okay. So this is something that you should know. Okay, this area is somehow is important area that questions are being asked. All right. Now let us move on and we see, can you identify this slide first of all? Can you identify this slide, beta? Now the hint over here is how to go about it. First of all, you have to identify one cell which is neither fitting in this side nor in this side. That means it is kind of a layer in itself. So we will assume it might be Purkinje cells. Our assumption will be made like confirmed by the presence of the black dots, that is the granule cells over here. So we can say definitely these are the Purkinje layer, granular layer, and this will be molecular layer, correct? Now the Purkinje cells have been marked. So Purkinje cells have been marked in the cerebellum, right? So where they are going to be, where they are going to influence? Straightforward answer is deep nuclei of cerebellum. Very good, beta. What are the deep nuclei of the cerebellum? For the deep nuclei of the cerebellum, we have this mnemonic: doctors eat good food. That is from lateral to medial. This is the arrangement. That is dentate nucleus, emboliform, globose, and fastigial. Yes, very good, good beta, good, very good, शाबाश. ठीक है, so far so good. यहाँ तक का सारा कुछ क्लियर बेटा, आगे बढ़े. Identify the pelvic diaphragm here. Which one is the pelvic diaphragm? Pretty easy question, but it has been asked. Okay, so answer will be C. That is levator ani. That is levator ani. And can you tell me what is the name of this muscle? This will be obturator internus. This will be obturator internus muscle. And now, if you guys can tell me what is this canal D? What is D? Yes, D क्या है बेटा? D है pudendal canal. D है pudendal canal. Inside the pudendal canal, what is present is pudendal nerve and pudendal vessels. So inside the pudendal canal, we have pudendal nerve and pudendal vessels. And pudendal nerve has got relationship with the ischial spine. So in order to do the pudendal nerve block, we have to first do the PV examination, search for the spine, because around the spine we have the pudendal nerve. Okay. Now this question, beta, that is which of the following is not a branch of anterior division of the internal iliac artery? Internal iliac artery, direct questions are asked from here, from the anterior division and posterior division. So let me do the revision here. Let me do the revision. Internal iliac artery, okay, it is having two division, that is anterior and posterior. From the anterior and posterior, we need to know the branches names. From the anterior, beta, we have the mnemonic, that is Shiv obtained marks in PG. Shiv obtained marks in PG. And from posterior, as you all are saying, Sil is the branch. Very good. Good to see that you remember everything. Very good, beta. Shabash. Now here we have superior vesical artery and inferior vesical artery. Okay, superior vesical artery, inferior vesical artery, and obturator artery, middle rectal artery, internal pudendal artery, and inferior gluteal artery. S will be superior gluteal, iliolumbar, lateral sacral, like that. But in case of female, because vesicle means the bladder and the inferior vesicle means the lower part of the bladder where prostate is present, correct? But in case of female, prostate is absent. Inferior vesical artery as such is not required. That's why in case of female, inferior vesical artery is replaced. Inferior vesical artery is replaced by which artery? By vaginal artery and uterine artery, like that. So far so good. Gonadal artery, Sanjay, is not a branch of the internal ilia. Gonadal artery is a branch of abdominal aorta. And gonadal veins will drain, like it will depend, right gonadal vein into the IVC, left gonadal vein will be into the left renal vein. Are you able to follow? So aorta will bifurcate into common iliac. Common iliac will bifurcate into external and internal iliac. Now you just visualize your abdomen. We have the aorta bifurcating common iliac artery, then two external iliac artery going to the lower limbs, and internal iliac artery going to the pelvic region. Are you able to follow? So in the pelvic region we have the internal iliac artery. It will be supplying all the structures over there. Gonadal artery is a branch from the aorta. Making sense? So far so good. All everything fine, beta? All of you are done up to this much part? Yes, very good. That is the mnemonic that we have learned for the lateral branches: inferior phrenic, middle suprarenal, renal, and the gonadal. Very good, beta Sunanda. Take it out, sir. All of you are done up to this much? Yes. Now this, what is the name of the condition? What is the name of the condition? Name of the condition is Digeorge syndrome. And because the thymus is absent and one part of hypoparathyroidism, means third pouch straight away, because third pouch makes the thymus and third pouch makes some part of parathyroid also. So the A is defective over here. What is first pouch? Tubotympanic, tympanic cavity and the auditory tube. What is second? Tonsil. What is third? Thymus along with some parathyroid. Here we have ultimobranchial body for the C cells and some part of parathyroid. Okay, this will be inferior parathyroid, this will be superior parathyroid. But answer to this question will be A. Yes. So dear friends, pharyngeal arch derivative, pharyngeal pouch derivative, and the neural crest cells, these you have to remember, you have to visualize. Okay, please remember those structures and keep on revising. Okay, this was all that we had to do today. All right, dear friends, and if you have any doubt, feel free to ask me here. I hope you enjoyed the session. I hope you could understand everything today. Okay, and see, as I said, I always say this: believe in yourself, believe in God, and miracle will happen. Okay, first of all you have to believe in yourself and then keep on doing all the hard work. Okay, do not go into the self doubt, and also do not waste time in the guilt. Sometimes, like many students, they will contact that I have wasted time, and then again they are wasting time in the guilt. So second wastage of the time that you can save. Okay, so thank you so much, dear friends. Okay, it was my pleasure meeting you guys across the screen, and I'm looking forward to meet you guys in person. Once you have cracked the exam, come and meet us. Okay, in the Dams Delhi, we all are waiting for you guys, and I am praying to God for from core of my heart for you guys grand success. All the very best. God bless you all. Take care. Bye bye.